Gastrointestinal stromal tumors. Margaret von Mehren. 33 GISTs comprise 1% to 3% of all malignant GI tumors. They are the most common mesenchymal tumor of the GI tract. More than 20 years ago, a seminal discovery was made that began elucidating the pathogenesis of most GISTs at the molecular level. 1 Moreover, this new understanding has been translated into highly effective, molecularly targeted therapies, such as imatinib mesylate and related drugs, for the majority of patients with GISTs. 1 Pathology. The term gastrointestinal stromal tumors was initially coined as a purely descriptive term by Mazur and Clark in 1983 to define intra-abdominal tumors that were not carcinomas, i.e., non-epithelial tumors, but exhibited histologic features of smooth muscle and neural elements. 2 At that time, the morphology of the tumor cells was the dominant feature driving the diagnosis. Expression of differentiation antigens used as markers for muscle cells, e.g., smooth muscle actin, and for nerve cells, e.g., S100, was noted to vary widely in GI mesenchymal lesions, leading to interesting hypotheses about whether GIST lesions from different patients were attempting to recapitulate distinct myogenic or neural programs of differentiation. To accommodate these empirical observations, it was proposed that approximately 1/3 of GIST lesions differentiated along smooth muscle lineages, another third were neurogenic in origin, and the final third lacked any detectable lineage-specific markers, null phenotype, by immunohistochemical analysis. 3-5 Before 1999, there was no objective, reproducible, and clearly defined criteria for the diagnosis and classification of GISTs. They were often misdiagnosed as leiomyomas or leiomyosarcomas because of the histologic resemblance to these smooth muscle neoplasms. Other terms that were often applied to GISTs included benign leiomyoblastoma 6 and, recognizing some of the neural characteristics, plexusarcoma 7 or gastrointestinal autonomic nerve tumors. 8 Insightful studies by several pathology groups noted that the panoply of tumors lumped together as smooth muscle tumors of the GI tract were likely not simply leiomyosarcomas nor benign leiomyomas. A subset of these tumors originating in the bowel wall had several unique histologic features, probably representing a totally different diagnostic group altogether. 9-10 The interpretation of published GIST series accumulated before 2000 is difficult given the heterogeneity reflected by the diagnostic term gastrointestinal stromal tumors as well as the underdiagnosis of the entity before widespread use of specific kinase-directed diagnostic and molecular markers. Immunohistochemical analyses of GISTs in the early 1990s attempted to find specific markers that might distinguish GISTs from other spindle cell tumors of the GI tract, such as schwannomas and sarcomatoid carcinomas. There was some initial enthusiasm for the CD34 antigen as such a marker, however, this antigen is also expressed by hematopoietic stem cells and by vascular and myofibroblastic cells. Also, the sensitivity and specificity of CD34 are low because only about half of GIST cases express CD34, and other smooth muscle, myofibroblastic, e.g., desmoid or Schwann cell tumors can also express CD34. 12 A critical advance in the understanding of GISTs at the molecular level occurred in the late 1990s with the recognition that the cells of these tumors exhibited some histopathologic similarities with the pacemaker cells of the gut known as the interstitial cells of Kagel. ICCs. 13 ICCs are normally present in the myenteric plexus and serve to coordinate gut peristalsis by assisting the linkage of smooth muscle cells of the bowel wall with the autonomic nervous system. See chapters 98 to 100. GIST cells in ICCs have certain common ultrastructural features, such as the combination of neural and muscle phenotypes. Furthermore, many if not most extragastrointestinal tissues throughout the body have interstitial cells resembling ICCs, first referred to as ICC-like cells. They are now called telocytes. Telocytes have lengthy prolongation that can influence other cells. 14 Telocytes may be the precursors of GISTs and extra-GI stromal tumors, such as pancreatic GISTs. 15-16 By immunohistochemical staining, GISTs characteristically, 95%, exhibit expression of CD117, mast/stem cell factor receptor. 1 Other names for this receptor include proto-oncogene c-KIT, tyrosine kinase receptor KIT, or simply KIT. CD117 is encoded by the KIT gene. Levels of expression of CD117 are generally diffuse and strong in the spindle cell GIST subtype, Fig 33.1. In contrast, in the epithelioid GIST subtype, CD117 expression is typically focal and weakly positive in a dot-like pattern, Fig 33.2. As discussed later, there are rare CD117 negative GISTs. True leiomyosarcomas express two smooth muscle markers, smooth muscle actin and desmin, but fail to express CD117. Schwannomas are usually positive for the neural antigen S100 but are also negative for CD117. Normal mast cells and ICCs within the surrounding stromal tissues serve as ideal positive internal controls because these normal cells strongly express CD117. GIST lesions can be heterogeneous in the expression of CD117, even within a single tumor. It is, therefore, possible that a needle biopsy may yield cells histologically consistent with a GIST yet be CD117 negative simply due to sampling bias. There are rare subsets of GISTs, 5% of cases overall, that have no CD117 expression. These are most likely dependent on an alternative kinase, such as mutated platelet-derived growth factor receptor alpha, PTCRA. See section on molecular pathogenesis. Point 17. The definitive diagnostic criteria of uncommon CD117 negative GISTs has been aided by the identification of DOG 1.18. DOG 1, which stands for discovered on GIST, is the protein TMEM16A or anoctamin 1, that functions as a CA2+ activated chloride channel. Point 19. DOG 1 has been found to be positive in 98% of GIST, importantly in those who have PTCRA mutations and may not express KIT. This marker has become a standard for GIST diagnosis in many pathology departments. An additional marker reported to aid in the diagnosis of KIT-negative GIST is PKC-theta20. 96% of KIT-negative GIST were found to express PKC-theta. It should be noted that both DOG1 and PKC-theta are also expressed in KIT-positive GIST. Therefore, the diagnosis of a GIST should be made on the grounds of morphologic, clinical pathologic, and immunohistochemical data, as well as possibly molecular analysis if there is any ambiguity from the other pathologic assessments. See section on molecular pathogenesis. It is also possible for a CD117 positive GIST to dedifferentiate as it becomes anaplastic and loses its ability to express CD117.21. Criteria for estimating the risk of malignant behavior of GIST was initially based on a consensus published by pathologists with expertise in GISTs who met at the National Cancer Institute. Point 22. This consensus conference defined the two most reliable prognostic factors for behavior of a primary GIST as 1. The size of the primary tumor and 2. The number of mitoses, reflecting the proliferative activity of the cells. Point 22. Additional factors are now recognized as important in terms of prognosis. Tumor location is also relevant, with primary tumors of the stomach having a better prognosis compared to those arising at other sites. In addition, primary tumors that undergo perforation prior to or during resection have a particularly poor prognosis. Point 23,24. Other factors besides size and mitoses, such as the specific histologic subtype, epithelioid versus spindle cell, see Figs 33.1 and 33.2, degree of cellular pleomorphism, and patient age, may have some contribution to prognosis but are most likely to play a minor role in determining the clinical outcome. Nomograms and staging systems have also been published to assess risk of recurrence after primary resection. Point 25,26. The GIST nomogram, developed by investigators at Memorial Sloan Kettering Cancer Center 25, is available online, https://www.mskcc.org/nomogram/gastrointestinal. Although simple, there is concern that the risk assigned to tumors arising in the stomach is too high compared to other risk criteria. The population-based topographical maps of disease recurrence by Joanne Suyu and colleagues provides the greatest clarity, as size and mitotic count are measured as continuous variables. This tool also takes into account evidence of rupture. Point 26. A simplified rule of 5S has been advocated in which size larger than 5 cm and more than 5 mitoses per 50 high-power fields, HPFS, define an intermediate high-risk gastric GIST and in which size larger than 5 cm or more than 5 mitoses per 50 HPFS. Define an intermediate high-risk non-gastric GIST. 27 Molecular pathogenesis. The molecular pathogenesis of GISTs was advanced in 1998 by the key observation made by Hirota and colleagues. 28 This group was studying the role of the protein KIT, CD117, in cell growth. AB Fig 33.1a, photomicrograph of a typical spindle cell GIST. The cells are monomorphic, have abundant pale, eosinophilic, fibrillary cytoplasm, and lack mitotic activity. HNE, times 100. B, KIT, CD117, immunostaining. This medium-power photomicrograph of a spindle cell GIST shows diffuse and strong cytoplasmic immunoreactivity for KIT. The entrapped muscle fibers from the bowel wall are negative by CD117 immunostaining for KIT. CD117 immunostain, times 100. Courtesy Dr. Brian P. Rubin, Cleveland, O. Fig 33.2 Photomicrograph of a gastrointestinal stromal tumor showing epithelioid cytomorphology, fibrillary cytoplasm, and lack of mitotic activity. HNE, times 200. Courtesy Dr. Brian P. Rubin, Cleveland, O. 460 Part 4 Topics involving multiple organs and development. In normal cell signaling, KIT binds its ligand, mast/stem cell factor, SCF, which results in the dimerization of two KIT molecules. The homodimeric complex formed leads to cross-phosphorylation of critical tyrosine residues in the intracellular domains of KIT, which activates signal transduction pathways downstream of KIT. The net physiologic effect of normal ligand-induced KIT activation is the controlled stimulation of cell proliferation and enhanced cell survival. Therefore, uncontrolled KIT activation could theoretically lead to neoplastic growth and transformation of cells. Hirota and colleagues provided the critical confirmation at the cellular and molecular levels that mutations in KIT were present in GIST and could lead to the development of GIST in a mouse model. 28 This same team, in a project led by Nishida, also expanded these observations to patients with familial GISTs, with germline activating mutations in KIT. 29 This elegant work supported some of the key biological similarities between GIST and ICC cells. 3031 Because both cell types express CD117. The cells of GISTs and normal ICCs likely share a common precursor cell, probably a stem cell. 13, 3031 KIT and its ligand SCF play essential roles in development and maintenance of normal ICCs, as well as other cells, including melanocytes, erythrocytes, germ cells, and mast cells. KIT expression is noted in the vast majority, 95%, of GISTs, but KIT is not expressed by true smooth muscle tumors of the GI tract, i.e., leiomyomas and leiomyosarcomas, nor by stromal tumors at other anatomic locations, such as endometrial stromal tumors. Although the origin of the neoplastic cells of GISTs remains a matter of active investigation, some data suggest that GISTs originate from CD34 positive stem cells residing within the wall of the gut, which can then differentiate incompletely toward the ICC phenotype. 3031 Activating mutations in KIT were identified in 5 of 6 cases of human GISTs originally analyzed by Hirota and colleagues. 28 With evidence that the mutations resulted in uncontrolled ligand-independent activation of KIT, or constitutive activation of KIT resulting in phosphorylation of the receptor in the absence of ligand. Genetically engineered cells harboring the mutant overactive KIT proteins were tumorigenic in nude mice, serving as proof of concept that the malignant phenotype was directly induced by the aberrant signaling pathways associated with uncontrolled ligand-independent KIT activation. The oncogenic potential of mutant constitutively activated KIT in the pathogenesis of GISTs in humans has also been supported by identification of familial syndromes, see section on familial GIST, with an autosomal dominant inheritance pattern and an abnormally high incidence of GISTs, usually occurring as multiple foci within any affected individual. 29 32-33 Genetic analysis of such kindreds reveals that they harbor germline activating KIT mutations similar to the mutations that were first described in sporadic cases of GISTs. Importantly, the vast majority of GIST cells at initial presentation demonstrate a single site of mutation in KIT. A variety of other genetic and cytogenetic changes are found, some of which are related to an aggressive malignant behavior. 34-35 gain of function mutations have been identified most commonly in exon 11 of KIT, an exon that encodes the intracellular juxtamembrane domain of KIT. 36-41 certain mutations in exon 11 that result in stop codons or deletions convey a poorer prognosis. 41 mutations have also been identified in KIT exon 938, the extracellular domain of the kinase, and less commonly in exons 13 and 17, kinase domain. 35-39 with rare occurrences of mutations in exon 8.40. The distribution of mutations varies based upon those with primary tumors compared with those seeking therapy for advanced disease. Table 33.1. 42-43 Structural biology studies have revealed the mechanism whereby normal, wild-type, KIT is kept in an autoinhibited conformation until its ligand, SCF, binds and leads to dimerization of two KIT kinases. Mutational changes lead to protein conformations that interfere with this autoinhibition and lead to the structural basis for the aberrant activation of the KIT kinase. 44-45 As will be discussed, imatinib mesylate and some other tyrosine kinase inhibitors TKIs can block this aberrant activation and kinase activity in these mutated tumors. Another key advance in the understanding of GISTs was the recognition that signaling through other uncontrolled kinases besides KIT could drive the neoplastic phenotype of GIST cells. Specifically, it is now recognized that at least 10% of GIST cells have mutational activation of the structurally related kinase known as the PTK, most often in exon 18, but also in exon 12, see Table 33.1. 17-43 Familial cases of GIST have also been identified with germline PTK mutations and are discussed later. 46-48 KIT and PTK mutations have been documented even in small GISTs, 1 cm in greatest dimension. 49-50 Such lesions are most often detected incidentally, e.g. gastric or esophageal GISTs during upper endoscopy for reflux symptoms, and may appear morphologically benign. These findings support the hypothesis that activating mutations in the KIT or PTK proto-oncogenes represent an early event in the transformation from a normal precursor cell into a GIST lesion. Because lesions in familial GISTs with germline KIT or PTK mutations, see section on familial GIST, may not present clinically until the second or third decade of life, or even much later, it is likely that second hits are necessary to attain a more aggressive malignant phenotype. Other key signaling steps that confer a more malignant phenotype to GIST cells remain obscure. However, the unique aspects of the signaling cascades in GISTs are being actively elucidated, and these appear to differ from KIT signaling in hematologic cancers. For example, the STAT5 pathway of leukemic cells is not typically activated in GISTs, whereas STAT1 and STAT3 are activated at a high level. 36 There is now consensus that the KIT genotype alone cannot account for differences between GISTs that may behave in an indolent manner, and which, when small, are likely to be curable by resection alone, versus those that are clearly aggressive and malignant by all functional definitions. Well-differentiated benign cell morphology alone should not provide any reassurance that an individual GIST lesion will pursue a benign clinical course. However, gastric GIST lesions smaller than 2 cm are considered benign and if removed do not require follow-up. 51 Table 33.1 Frequency of particular KIT and PTK mutations in newly diagnosed gastrointestinal stromal tumors as compared with metastatic gastrointestinal stromal tumors newly diagnosed. 42 Metastatic disease 43 GISTs, N. 106 414 KIT mutations 67% 81% exon 8 not reported 1% exon 11 53% 71% exon 9 9% 8% exon 13 4% 1% exon 17 1% 1% PTK mutations 16% 2% exon 12 2% 1%. Exon 14 0% 0% exon 18 15% 2% wild type KIT and PTK 17% 17% PTK. platelet-derived growth factor receptor alpha. Chapter 33 Gastrointestinal Stromal Tumors 461-33 Approximately 5% to 10% of GISTs are wild-type for KIT and PTCFR, i.e., have no mutations in these two key genes. Point 1 Many of these GISTs have been recognized to have loss of expression and function of succinate dehydrogenase, SDH, proteins. The SDH proteins are a family of enzymes, SDHA, B, C, and D, that form a complex in the wall of the mitochondria critical for cellular respiration. In some cases, SDH genes are mutated, but in others there is hypermethylation of the genes, including the promoter for SDHC, leading to loss of expression and activity. These tumors can be identified by loss of SDHB staining in tumor cells. They have also been found to express high levels of insulin-like growth factor 1 receptor. 52-57 These tumors are now called SDH-deficient GISTs, Carney triad and the Carney-Stratakis dyad, discussed in the section on familial GIST, are syndromes whose GIST have this oncologic mechanism. This form of GIST arises in the stomach, may be multifocal and metastasize to lymph nodes. Tumors are more common in females and tend to be diagnosed at an earlier age than typical mutant GIST. Most GIST in the pediatric age group are SDH-deficient GIST. A rare mutation in patients without KIT and PTCFR mutations involves BRAF, which encodes for BRAF, serine/threonine protein kinase BRAF. 35,58 Recently, reports of other actionable mutations involving fibroblast growth factor receptor 1 and neurotropic tyrosine receptor kinase, NTRK, have also been reported. 59 In addition to the genes and proteins already discussed, other genes, transcription factors, microRNAs, and pathways have been reported to play a role in the pathogenesis, behavior, diagnosis, and prognosis of GISTs. 60-77 Some of these will be undoubtedly important predictors of outcome or provide therapeutic targets in the future. A detailed discussion of these many factors is beyond the scope of this chapter. Molecular pharmacology identification of KIT mutations provided critical understanding of the pathobiology of GIST and provided an appealing therapeutic target. It was serendipitous that a medication being developed for an entirely different purpose showed dramatic inhibition of KIT activity. The initial concept for this molecularly targeted approach came from efforts to develop small molecules against BCR-ABL, the oncoprotein target critical to the pathogenesis of chronic myeloid leukemia, CML. A small molecule in the 2-phenylamminopyrimidine class was identified by Drucker and colleagues at Novartis that demonstrated potent inhibitory in vitro activity for ABL and the dysregulated BCR-ABL. 78,79 Additional screening studies from the laboratories of Drucker and Buchdunger and Associates demonstrated that this agent, signal transduction inhibitor 571, ST 571, subsequently called imatinib mesylate, Gleevec in the USA, Gleevec elsewhere, could also potently inhibit the tyrosine kinase. Activity of both KIT and PTCFR. 80 Subsequent studies performed in a human mast cell leukemia cell line that harbored a KIT mutation similar to the mutations noted in GISTs documented that imatinib could inhibit both wild-type and mutant KIT protein. 81 Laboratory experiments testing imatinib in human GIST cell lines with defined activating mutations of KIT revealed dramatic evidence of anti-GIST activity. Addition of imatinib to cultured human GIST cells rapidly inhibited KIT activation, arrested cell proliferation, and induced apoptosis in the tumor cells. 82 By all criteria, therefore, the clinical development of imatinib was promising as a treatment of GIST to target the fundamental molecular pathogenesis of this disease. Treatment of GISTs with imatinib mesylate and other tyrosine receptor kinase inhibitors are discussed later. Epidemiology It has been difficult to obtain accurate data regarding the true incidence of GISTs. This is because of referral bias, which concentrates GIST cases with a worse prognosis and a more malignant behavior into academic cancer centers, and the lack of definitive diagnostic techniques before the molecular definitions of GISTs in 1998 and beyond. Before 2000, the number of new GIST cases was underestimated and underreported. With the understanding of the molecular underpinnings of GISTs and the availability of molecularly targeted drugs, there has been an increase in the diagnostic accuracy of the disease. 83 A recent study using the surveillance, epidemiology, and end results (SEER) database of cases diagnosed between 2001 and 2011 found an increase in the age-adjusted incidence from 0.55/100,000 in 2001 to 0.78/100,000 in 2011. The incidence increased with age and was highest in the 70 to 79 age group, at 3.06/100,000.84. The incidence has been reported to be slightly higher in men than women. 84 Studies of gastrectomy specimens resected for non-neoplastic diseases and autopsy studies have documented a remarkably high incidence of occult microscopic GIST lesions, in the range of 20% to 35%. 85,86 Clinical features. Most GISTs, 60% to 70%, arise in the stomach, 20% to 30% originate in the small intestine, and less than 10% in the esophagus, colon, and rectum. GISTs can also occur in extragastrointestinal, abdominal or pelvic sites such as the omentum, mesentery, or retroperitoneum. 87-100 including the pancreas. Extragastrointestinal tumors are termed e-GISTs. 16 The clinical presentation of patients with GISTs depends on the anatomic location of the primary lesion, as well as other factors like tumor size and presence or absence of symptomatic metastases. For many GIST patients, initial detection of GISTs may be an incidental finding or result from evaluation of nonspecific symptoms. Symptoms from GISTs per SE are usually noted only after tumors are larger than 5 cm in size or have impinged on a specific anatomic region, e.g., a gastric GIST causing gastric outlet obstruction. Symptoms at presentation may include a palpable abdominal mass or abdominal swelling, abdominal pain, nausea, vomiting, anorexia, and early satiety. It has been reported that up to 40% of patients with GISTs present with acute hemorrhage into the GI tract or into the peritoneal cavity from tumor rupture. However, such reports are likely dependent on referral bias of patients with large GIST lesions or multifocal disease. Some will present with anemia as a consequence of chronic blood loss. Because a GIST may not be identified by routine endoscopy, consideration of abdominopelvic imaging should be considered as part of an iron deficiency anemia workup with negative GI endoscopy studies for a source of bleeding. See Chapter 20. The vast majority of metastases from GISTs, at presentation or with disease recurrence, are intra-abdominal, with metastases to the liver, omentum, or peritoneal cavity. 88 Metastatic spread to lymph nodes and other regions is rare. Most lesions thought to be nodal metastases by imaging studies simply represent metastatic deposits of tumor nodules in the omentum or peritoneum rather than true lymphatic spread of the disease. Sites of metastases seen in advanced disease can also include the lung and bone. GISTs can express a thyroid hormone inactivating enzyme, type 3 iodothyronine deiodinase, that can result in a consumptive type of hypothyroidism, requiring supernormal doses of thyroid hormone therapy. 91 Esophageal tumors. GISTs may arise within the esophagus, although this is a rare presentation for larger lesions. 92-94 Most esophageal GIST lesions are noted incidentally during upper endoscopy performed for some other unrelated symptom or disorder, such as reflux esophagitis. Esophageal GISTs may be small, only a few millimeters in size, and may be resected using endoscopic techniques. 95 462 Part 4 Topics involving multiple organs. Margins may be involved if a lesion, unsuspected as a GIST and thought to be benign, is simply enucleated endoscopically. It remains unclear whether watchful waiting with serial endoscopic follow-up is appropriate for any patient with small GIST lesions, 1 cm in maximal dimension. Larger esophageal GISTs may perforate. 96 On imaging, they appear like GISTs elsewhere in the GI tract. They tend to be well circumscribed 18 FFDG avid, hypoattenuating, and spread locally, e.g., to the pleura, or hematogenously, e.g., to the liver. 94 As noted, histopathology showing putatively benign GIST cells cannot be viewed reassuringly because histology does not perfectly predict the malignant behavior of GISTs. A careful risk-based assessment includes accounting for other aspects of the tumor, as well as patient-specific factors, e.g., age, comorbidities, patient preferences. It will be important for prospective studies to accumulate a larger objective database regarding the outcomes of such patients so that medical decision-making can be based on solid evidence. Although a small esophageal GIST lesion is probably a single primary, it is appropriate to take a careful family history and perform CT of the abdomen and pelvis to ensure no other lesions are present, especially if the disease is first detected in a young person. Some series have attempted to distinguish between clinical outcomes of patients with GISTs and those with leiomyosarcomas or other mesenchymal neoplasms, such as leiomyomas. 92 Gastric tumors. The most common primary site for GISTs is the stomach, Figs. 33.3 and 33.4. They can be asymptomatic or present with bleeding, pain, or obstruction. Most GIST lesions as seen endoscopically are submucosal rather than mucosal, without overlying ulceration. This explains why many GIST masses may only be visualized on endoscopy as a subtle, smooth protrusion with overtly normal mucosa. 97 Also, this submucosal localization can make diagnostic biopsy through an endoscope difficult. It is not uncommon for superficial biopsies to reveal only normal mucosa, whereas deeper biopsies or histopathology from a definitive resection would show the true underlying GIST cells. The use of EUS often allows for appropriate sampling and adequate diagnostic biopsies. Duodenal and jejunal tumors. The second most common site for GISTs to arise is in the small intestine. 98,99 In one report, approximately half of all small bowel tumors identified on small bowel capsule endoscopy were GISTs. 100,101 GISTs in the small intestine tend to occur in the jejunum, followed by the ileum and then the duodenum. More investigators are now separating duodenal GISTs from other small intestinal GISTs because of differences in presentation and behavior. Duodenal GISTs seem to have a more favorable prognosis than jejunal GISTs, even with resections that are more conservative and limited, i.e., without performing a pancreaticoduodenectomy. 102-106 Small intestinal GISTs often present with significantly larger lesions than other primary sites. The large lesions may be highly vascularized and present significant risks of bleeding, even with only a biopsy. Because complete surgical resection is the treatment of choice for GISTs, there is some controversy over whether any preoperative biopsy is necessary, or whether biopsy represents an extra risk for the patient, discussed further below. This is a challenging subject because other disease entities enter into the differential diagnosis of a large abdominal mass involving the small intestine and mesentery. In general, clinical practice. Fig. 33.3 Photomicrograph of a spindle cell submucosal gastrointestinal stromal tumor in the stomach. The lesion is well circumscribed and does not invade the overlying muscularis mucosa. Invasion of the muscularis mucosa is considered an adverse prognostic factor. H.N.E. times 50. Courtesy Dr. Brian P. Rubin, Cleveland, O. A.B. Fig. 33.4 Gastric GIST. A. CT showing a 4 to 5 cm exophytic gastric GIST arising from the greater curvature of the stomach, arrow. B. Gross photograph of the 3.5 times 4.5 times 4 cm tumor after it was resected and cut open. Histology showed a spindle cell gastric GIST that was positive for KIT, CD117, immunoreactivity. Courtesy Dr. J. N. Yepuri and Dr. Christopher Bell, Dallas, TX. Chapter 33 Gastrointestinal stromal tumors. 463-33 guidelines have suggested that resection may be performed without antecedent biopsy if a GIST is strongly suspected and if surgery can be accomplished without significant risk of morbidity to the patient. If only radical surgery, leading to significant functional impairment, could remove the lesion, it may be in the patient's best interest to consider a preoperative biopsy to establish the diagnosis of a GIST and allow for neoadjuvant therapy, see below. Colonic and anorectal tumors. GISTs in the rectum and colon are rare, accounting for roughly 5% of GIST cases, and they present unique management challenges. 107-112 As in other sites, small GIST lesions in the rectum may present as small, hard nodules less than 1 cm in diameter found incidentally during a rectal examination or proctoscopy. However, much larger tumors can ulcerate and bleed acutely or chronically, mimicking a rectal adenocarcinoma. Diagnosis can be challenging because the epithelioid or mixed cell variants of GISTs can also be misclassified as adenocarcinomas, especially if small biopsies are confounded by severe inflammatory changes or associated abscess formation. Diagnosis. Several professional organizations have developed consensus-based, and, whenever possible, evidence-based, clinical practice guidelines. The National Comprehensive Cancer Network has developed extensive publicly accessible guidelines to assist clinicians in the diagnosis and treatment of GIST patients. See the GIST and soft tissue sarcoma guidelines on www.nccn.org. The European Society of Medical Oncology, ESMO, also has published expert-driven clinical practice guidelines. 113 The diagnostic evaluation of a suspected or proven GIST resembles that of other GI neoplasms. The most important element is to keep GISTs in the differential diagnosis of any mass lesion noted throughout the length of the GI tract, as well as in extra-intestinal sites of the abdomen and pelvis. As for any GI evaluation, the site of lesion determines which diagnostic tools are most appropriate for the patient. Endoscopy plays a major role in the diagnosis of gastric, duodenal, esophageal, colonic, and anorectal GISTs. Capsule endoscopy is valuable in diagnosis of jejunal and ileal GISTs. 100,101. Double balloon enteroscopy may also be useful in diagnosis of these small intestinal GISTs, especially those that bleed. 114 Imaging EUS is a useful technology for evaluating possible GISTs because of the submucosal localization of these tumors. See video 33.1. GISTs visualized by EUS appear as hypoechoic masses contiguous with the fourth, muscularis propria, or second, muscularis mucosae, layers of the normal gut wall. In one study 115-7 the EUS features most predictive of so-called benign GI GISTs were regular margins, tumor size 3 cm or less, and a homogeneous echogenicity pattern. Multivariate analysis identified the presence of cystic spaces and irregular margins as independent predictors of malignant potential. A second study identified tumor size larger than 4 cm, irregular extraluminal borders, echogenic foci larger than 3 mm, and cystic spaces larger than 4 mm as factors that correlated with malignant behavior in GIST. 116 CT and MRI. CT is the most effective way to image primary lesions in the stomach, because the oral contrast will outline masses and gastric thickening. See Fig 33.4. The differential diagnosis with inadequate gastric distension can be a challenge, especially when monitoring for recurrence following surgery. CT is also essential to stage the extent of disease. For measurable GISTs, it is particularly useful to perform CT with non-contrast image acquisition, as well as assess early and late images following administration of contrast. Routine MRI is inferior to CT for visualizing a gastric GIST because of uncontrollable movement of the gastric wall and surrounding tissues. However, diffusion-weighted imaging with MRI may be comparable to PET/CT. 117 MRI can be useful for assessment of liver metastases because some GIST lesions can be fully isodense to normal tissues and thus invisible against surrounding hepatic parenchyma on CT. Baseline CT imaging is critical for patients with GISTs, because endoscopic imaging alone may only reveal a small fraction of the underlying tumor. Additionally, imaging patterns can be interpreted qualitatively to assess the impact of targeted therapy using metrics other than tumor size. 118,11921 Response to kinase inhibitors will lead to a decrease in tumor density on CT, even in the absence of a change in size of the lesion. Choi criteria. Hypodense lesions on CT have been correlated with loss of metabolic activity on FDG PET imaging. 119 PET/CT. One of the most impressive aspects of GIST diagnostic imaging is the use of F-fluorodeoxyglucose, 18F-FDG, PET scans to add complementary information to that obtained by conventional anatomic imaging. Fig 33.5. Although CT or MRI can assess the size of GIST lesions accurately, the functional imaging of GIST with 18F-FDG PET can provide useful additional information that can assist clinicians in the management of GIST patients. The actual mechanisms responsible for the high level avidity of GISTs for the 18F-FDG tracer is likely due to signaling through the overactive KIT, RTK, and glucose transport proteins, such as GLUT4.120. With therapy, there is decreased cell viability and glucose uptake associated with decreased GLUT4 expression, thus explaining the rapid changes in PET imaging associated with inhibition of KIT signaling by pharmacologic means. 121,122 Large GISTs can demonstrate centers with predominantly cystic or low attenuation characteristics noted on CT or MRI. It is clear by18F-FDG PET scans that the internal mass of large GIST lesions can often be viewed as metabolically quiescent, likely because of tumor necrosis of these large lesions in their central portions. Even though GIST lesions can be vascular, the internal portion can nonetheless represent a confluent mass of necrotic material, with the more viable portions of the GIST pushing out toward the edges of the lesion. Much of the added value of 18F-FDG PET imaging in serial imaging can also be obtained by qualitative assessment of tumor density obtained via CT. 119 However, occasionally, metastatic GIST lesions in the omentum can be subtle and easy to overlook on CT because small lesions could blend into the folds of the bowel walls and be difficult for even the most experienced radiologist to detect. 18F-FDG PET imaging can detect lesions about 1 cm or larger in size without difficulty because neither the normal bowel nor omentum will take up the 18F-FDG tracer with excess avidity. National guidelines, however, do not encourage the routine use of FGD PET imaging. Somatostatin receptor scintigraphy. Somatostatin receptor scanning is valuable in the diagnosis of GI and pancreatic neuroendocrine tumors, see next chapter. Recently, somatostatin receptors 1, 1 and 2 were shown to be expressed in the majority of GISTs, and the tumors could be visualized in half the patients studied using SRS with 111 enlabellated agents, see chapter 34. 123 This finding may permit 464 Part 4 topics involving multiple organs ABC. Fig 33.5 Metastatic GIST. PET, A, B, and CT, C, in a patient with a GIST metastatic to the liver, before, left, and after, right, treatment with imatinib mesylate. Partial tumor regression with reduced 18F-FDG uptake is seen after treatment. Courtesy Dr. A. van den Abeel, Boston, MA, and modified from Demetri G.D., Benjamin Rs., Blang C.D., ETALNCCN Task Force Report, Management of Patients with Gastrointestinal Stromal Tumor GIST Update of the NCCN Clinical Practice Guidelines. JNetL Compare CANC Net 2007, 5 Supple 2S1 S29. Chapter 33 Gastrointestinal Stromal Tumors 465 33 Peptide receptor-mediated radiotherapy as discussed in Chapter 34 for some of these GISTs patients in the future, but has not been evaluated to date. Biopsy. As discussed earlier, GISTs can be highly vascular, which may present an unacceptable risk for endoscopic biopsy. Additionally, percutaneous biopsies, even if only using FNA techniques, may impose risks of tumor rupture and tumor cell seeding along the biopsy tract or spread via peritoneal or mesenteric contamination. To minimize risk to the patient, many surgeons recommend that preoperative biopsy not be performed if resection is planned. However, biopsy must be performed in cases of unresectable GIST to make the diagnosis and justify preoperative, neoadjuvant, administration of imatinib therapy, discussed later. Furthermore, FNA biopsy of gastric GISTs using EUS guidance can be diagnostic and can be performed safely. 124 As can a mucosal incision-assisted biopsy technique. 125 For patients presenting with metastatic disease, biopsy is appropriate to establish a diagnosis and allow for initiation of systemic therapy. Differential diagnosis. GIST was originally described as a monomorphic spindle cell neoplasm. However, it is now clear that GIST can exhibit a wide variety of histologic appearances, ranging from an epithelioid form with large round cells, see Fig 33.2, to the spindle cell form, see Fig 33.1, and lesions with mixed histology. The spindle cell GIST variant is far more common, representing some 70% of cases. The epithelioid, or round cell, pattern represents most of the remaining 30% and may contain an admixture of spindle cells. The epithelioid subset was previously diagnosed as leiomyoblastoma, although some may have been mistaken for poorly differentiated carcinomas. The differential diagnosis of GI tract neoplasms that appear to be mesenchymal in origin includes GISTs, 80%, but there are definitely true smooth muscle neoplasms of the GI tract, including true leiomyomas and leiomyosarcomas, 15%, and schwannomas, 5%. CT features may help distinguish small gastric GISTs from gastric schwannomas. Also, gastric GISTs tend to grow faster when assessed with serial CTS than schwannomas. 126 As noted, expression of KIT is not limited to GIST cells. Normal ICCs and mast cells express CD117 and depend on KIT for normal growth and development. A relatively limited number of other tumors may also express immunohistochemically detectable CD117. These include certain subsets of soft tissue sarcomas, including Ewing sarcoma and angiosarcoma, as well as other neoplasms, such as occasional small cell lung cancers, melanomas, desmoid tumors, seminomas, ovarian carcinomas, mastocytomas, neuroblastomas, adenoid cystic carcinomas, and rare subsets of lymphoma and acute myeloid leukemia. 127-130 It is also relevant to note that expression of the CD117 antigen does not imply activation of the KIT target, nor does it necessarily correlate with any KIT gene mutation. The same CD117 antigen is expressed by cells harboring normal, wild-type, KIT as those that have activating KIT mutations. Also, expression of KIT protein does not necessarily mean that the protein is involved in the pathogenesis of that specific cancer. Treatment: primary localized disease, early stage disease, surgery. Definitive expert surgery remains the mainstay of treatment for patients with primary localized GISTs, early stage GISTs. The surgical approach to resection of primary disease must account for the specific growth and behavior characteristics of this disease. GISTs rarely involve the regional lymph nodes, and extensive lymph node exploration or resection is rarely indicated. GIST lesions are highly vascularized and often exhibit a fragile pseudocapsule, therefore, surgeons should be careful to minimize the risk of tumor rupture, which subsequently increases the risk of peritoneal dissemination. The margins of resection from the tumor specimen should be carefully oriented and examined, and biopsy samples from several different areas of the tumor should be evaluated by the surgical pathologist. More and more, laparoscopic 131-135 and endoscopic 136-137 resections are being used with good outcomes. The natural history of early-stage primary GIST has been examined in studies from single-institution referral centers. These studies are certainly prone to selection bias, and it is clear in this evolving field that many early-stage GIST patients have likely been managed by physicians from multiple specialties, including gastroenterology and general surgery. The Memorial Sloan Kettering Cancer Center's series evaluated 200 patients that were followed prospectively. 80 of these patients, 40%, had primary disease managed with complete surgical resection. This subgroup with primary resected GISTs demonstrated 5-year disease-specific survival rates of only 54%, supporting the fact that GISTs, as seen at such an academic referral center, can exhibit a high risk for recurrence and ultimately prove to be life-threatening. On multivariate analysis, large tumor size, greater than 10 cm, was the only factor that reduced disease-specific survival. Anatomic location of the primary tumor also appears to be an important prognostic factor for primary localized GIST. 90 As mentioned earlier, small intestinal GISTs have a less favorable prognosis than gastric GISTs. Colon/rectal GIST and E-GISTs, which are rare, have the poorest outcome. The prognosis of GISTs involving the small intestine is related to the adequacy of resection. 88-138 Most can be completely resected, with median overall survival of more than 5 years for patients with localized or locally advanced disease. Patients who underwent complete resections exhibit much better 5-year overall survival than those whose lesions cannot be completely resected. Cysts in the rectal and perirectal location present similar challenges to those in the small intestine. Specifically, if non-mutilating surgery can achieve negative margins for a tiny cyst, 1 cm, that is probably a reasonable way to proceed. However, many cyst lesions in the rectal region will prove more challenging to resect, and surgery may only be feasible with significant functional morbidity, especially if done without prior neoadjuvant therapy. Because there is now effective medical treatment for advanced cysts, imatinib, discussed later, it is important that all resected cyst patients undergo regular surveillance following resection. In this way, any recurrent disease can be detected and treated at the earliest stage, thereby hopefully avoiding complications, e.g., tumor hemorrhages, that might stem from treatment of recurrent large, bulky disease. Adjuvant radiation therapy. Only a limited number of case reports and small series have investigated the role of adjuvant treatment using conventional modalities, such as radiotherapy following surgical resection of an early-stage cyst. Radiotherapy does not appear to have an important role in the adjuvant treatment of cyst. This in part is due to the inability to administer effective doses given the toxicity to small bowel and other intra-abdominal structures. There also have only been small series of patients who have received adjuvant systemic or intraperitoneal chemotherapy, and these data have not identified any clear benefits. The standard of care after complete surgical resection of primary cysts had therefore been observation alone prior to the availability of imatinib. 466 Part 4 Topics involving multiple organs. Adjuvant therapy with imatinib. It is now clear that administration of imatinib in the post-resection, adjuvant, setting delays tumor recurrence, especially for patients who present with very large tumors and who are at very high risk of disease recurrence and metastatic spread. 139-144 Risk stratification for adjuvant therapy typically does not use the AJCC staging. Tumors estimated to be at intermediate to high risk of recurrence, using the GIST nomogram, population topographical charts, or the rule of fives discussed earlier are utilized. 25-27 The activity of adjuvant imatinib in GIST patients has been investigated in several large multi-center trials. 139-144 In the first randomized adjuvant trial Z9001, conducted by the American College of Surgical Oncology Group, icosug, imatinib, or placebo, was administered for 1 year. Administration of imatinib following resection of primary limited GIST significantly prolonged recurrence-free survival compared with placebo, 98% versus 83% free of recurrence at 1 year, hazard ratio 0.35, although no overall survival benefit has been noted. 139 The icosug trial enrolled patients with any size GIST. Analysis of the benefit from therapy based upon size, i.e., 3 to 6 cm, 6 to 10 cm, and 10 cm, or larger, identified that although there was a numerical benefit in all groups, it was only statistically significant in the tumors larger than 10 cm. The European Organization for the Research and Treatment of Cancer, EORTC, tested 2 years of adjuvant therapy versus none, and originally had overall survival as the primary endpoint. 141 It became clear that the results of this trial potentially would require more than a decade, and so the endpoint was switched to the time to imatinib-resistant disease. Patients who were on imatinib for 2 years and progressed were allowed to restart imatinib, and those on the placebo arm who progressed initiated therapy. There was no statistically significant difference in the time to imatinib resistance in the two groups. In the Scandinavian trial, 142-143 patients with KIT-positive GISTs by immunostaining that had a high likelihood of recurring postoperatively due to their size, mitotic rate, and/or occurrence of tumor rupture were randomized to receive adjuvant imatinib mesylate, 400 mg/day, for either 1 or 3 years beginning 1 to 12 weeks postoperatively. Imatinib therapy for 3 years resulted in significantly better overall survival than when just taken for 1 year. 91.9% versus 85.3%, HR, 0.60, P equals 0.036, although there was a higher imatinib discontinuation rate in the 3-year group, usually for adverse effects or patient preferences. In addition, This trial demonstrated a survival advantage for those receiving adjuvant therapy. 142,143 The PERSIST-5 study was a single-arm phase 2 study that enrolled patients with high-risk GIST, defined as a primary GIST, any site, greater than or equal to 2 cm with a mitotic count greater than or equal to 5/50 HPF or non-gastric primary GIST greater than or equal to 5 cm. 144 Imatinib maintained its effectiveness over the 5-year trial period. The benefit of adjuvant activity of imatinib is clear and merits a thoughtful discussion of possible risks and benefits in all patients with resected GISTs who are at moderate to high risk of disease recurrence by current risk classification systems. 22,25,26 Guidelines recommend treatment for at least 3 years. Studies are now ongoing to assess the benefit of longer-term therapy. Check clinicaltrials.gov. Neoadjuvant therapy. With the advent of highly effective drug therapy, current guidelines recommend that surgical resection of GISTs be undertaken as the first intervention only if there is an acceptably low risk of functional deficit or morbidity from the surgery. If a large GIST is detected, and there is a risk for perioperative morbidity, neoadjuvant, preoperative, imatinib should be considered. In this scenario, a tissue biopsy is required prior to starting therapy. The tissue from such a diagnostic biopsy is too small to provide detailed risk stratification but should be sufficient to obtain molecular testing. Trials have shown that such neoadjuvant drug administration can be effective at downsizing tumors and, hence, facilitating effective surgical intervention. 145-147 In this specific clinical situation, 18 FFDG PET scanning allows an early assessment of response, thereby minimizing the risk of disease progression that otherwise might put the patient at risk for becoming unresectable. Following the maximal response to imatinib, median time to maximal response being 6 months or longer, definitive surgery can be performed. In such patients, postoperative imatinib adjuvant therapy is also recommended for a total of at least 3 years of therapy. Advanced stage disease, systemic and locoregional chemotherapy, radiotherapy, and debulking surgery. Medical oncologists had noted that leiomyosarcomas of the GI tract had poorer prognosis than leiomyosarcomas arising in other parts of the body, e.g., the uterus. The leiomyosarcomas of the GI tract were far more resistant to standard chemotherapy regimens. These leiomyosarcomas proved largely to represent GISTs. Studies in patients with advanced GISTs receiving conventional cytotoxic chemotherapy demonstrated little benefit with objective anti-tumor response to various chemotherapy agents routinely reported to be 0% to 4%. 1,148 Some investigators attempted to improve on these dismal results with chemotherapy by administering the drugs via an intraperitoneal route. 149 However, because GISTs rarely remain confined to the peritoneal surfaces, with hematogenous spread to the liver and other intra-abdominal locations, and because most of the life-threatening complications of GISTs arise from hepatic involvement or from bulk disease affecting the omentum, this intraperitoneal approach was not particularly promising. Based on these disappointing results, conventional cytotoxic chemotherapy is regarded as ineffective for the treatment of patients with GIST. The high levels of resistance to chemotherapy exhibited by GISTs may result, in part, from the expression of increased levels of P-glycoprotein, the product of MDR1. GISTs have been shown to have increased expression of P-glycoprotein compared with leiomyosarcomas. 150 These cellular efflux pumps prevent some types of chemotherapy from reaching effective intracellular concentrations in the target GIST cells. There are single-institution data demonstrating control of metastatic GIST for a limited time by locoregional surgical or interventional radiology techniques, such as hepatic resection 151, hepatic artery embolization/chemoembolization 152, or radiofrequency ablation. 153 Although a subset of patients with metastatic GISTs involving the liver have demonstrated anti-tumor responses and a somewhat limited progression-free survival, PFS, following chemoembolization, the benefits are generally measured in months rather than years. These approaches are now used as adjuncts to other systemic management options. 154,155 Debulking surgery has a limited role in selected patients with metastatic GIST. If a patient presents with metastatic disease involving the liver and peritoneal surfaces, the first line of therapy is a TKI. Once the disease has responded to the TKI, the role of debulking surgery has been hypothesized to be of benefit by eliminating tumor that contains resistant clones and may prolong disease control, supported by PFS on imatinib being correlated with bulk of disease. 156 The EORT developed a trial to test this hypothesis in which patients were to be randomized to continued imatinib therapy versus resection of disease with continued imatinib, with the primary endpoint of PFS. The study accrued poorly and was closed before answering the question. Large series from several institutions have also reported on the benefit of limited resection in patients with progressive disease on TKI therapy. 157-161 The majority have reported on outcomes for patients on imatinib therapy. Although surgery is feasible with Chapter 33 gastrointestinal stromal tumors 467-33 sunitinib, it is complicated by the vascular endothelial growth factor receptor targeting of sunitinib, requiring the drug to be stopped for 2 weeks or longer prior to surgery due to increased risk of bleeding and wound complications. 158 In the setting of progressive disease on imatinib, patients with isolated progressive disease that is resected achieve approximately an extra year on imatinib therapy. There is limited benefit of surgery for diffuse progression and patients are better served by changing their systemic therapy. Radiotherapy plays a limited role in the management of patients with metastatic GIST. In part this is because delivery of therapeutic doses of radiotherapy to the liver or GI tract usually causes more morbidity than benefit. However, in the setting of advanced disease with painful bone metastases or bleeding from tumors, radiation therapy can play a palliative role. 162 Clearly, for patients with metastatic or unresectable GISTs, prognosis was dismal before the advent of molecularly targeted therapy. For patients with metastatic or recurrent GISTs or GI sarcomas, most of which were likely to have been a true GIST, most studies prior to the introduction of targeted therapy with kinase inhibition documented poor survival rates, with fatal outcomes from disease progression generally occurring within 1 to 2 years from the date of first recurrence or metastasis. 88 Imatinib mesylate The collaborative worldwide clinical development of imatinib as a molecularly targeted therapy of GIST proceeded at a dramatic pace. In 2000, a single patient pilot study in a patient with advanced, heavily pretreated, and widely metastatic GIST was undertaken. The patient had a rapid response with sustained clinical benefit from imatinib for nearly 3 years. 163 Based on the dramatic and durable benefits in this patient, as well as striking scientific rationale and strong preclinical data, other studies testing imatinib for GISTs were started. A dose-finding study, begun by the EORT sarcoma group, enrolled primarily patients with GISTs. 164 The maximal tolerated dose of imatinib was judged to be 800 mg/day, given as 400 mg twice daily, at the higher dose level of 1000 mg daily, given as 500 mg twice daily. Unacceptably severe, dose-limiting toxicities such as nausea, vomiting, and severe edema were reported. A multi-center U.S. Finland collaborative study randomized 147 patients with metastatic GISTs between 2 dose levels of the drug, 400 mg daily or 300 mg twice daily. 121 There did not appear to be differences in response rates or duration of disease control between the 2 dose levels, but the study was not powered to detect differences. The EORT group went on to expand its exploration of imatinib in GISTs and other forms of sarcomas. In this trial, the high levels of anti-tumor activity against GISTs were again confirmed, whereas there was no demonstrable benefit for patients with other forms of soft tissue sarcomas. 165 The results from these wholly independent trials were remarkably concordant, Table 33.2. These data supported the hypothesis that targeting the mutations in KIT and PTK believed to be the molecular drivers critical to GIST cell growth and survival leads to meaningful therapeutic benefit. Without such a target to inhibit, as in sarcomas other than GISTs, imatinib treatment does not have major anti-cancer activity. Further assessment of the optimal dose of imatinib for advanced unresectable GIST was obtained in 2 large trials designed and run concurrently by the Southwest Oncology Group, SWOG, and the EORT. 166,167 These studies enrolled 1,700 patients and were powered to determine whether 400 mg twice daily, compared to 400 mg daily, would translate into significant clinical benefits as measured by improved response rates, PFS, SWOG trial, or survival, EORT trial. In addition, progressing patients on the lower dose arm were allowed to cross over to the higher dose arm. There was no survival difference documented in either trial between these two dose levels. Although the SWOG study demonstrated only a favorable trend in the duration of disease control associated with the higher dose of imatinib, the European study noted a modest but statistically significant benefit in favor of the higher dose arm for PFS. In a combined meta-analysis, benefit of the higher dose of imatinib was limited solely to the relatively small subset of GIST patients whose tumors harbored mutations in KIT exon 9, encoding a mutation in the extracellular KIT domain that promotes dimerization of kinase molecules. 166 This has led to the recommendation by some experts to use the higher dose of imatinib as first-line therapy for advanced GIST in patients whose tumors have documented exon 9 KIT mutations. The benefit, however, should be weighed against the additional toxicities, because the higher dose of imatinib was associated with a greater incidence of adverse effects and led to a greater number of dose reductions for toxicity. This increase in toxicity can be mitigated, however, by initiating therapy at 400 mg/day and then escalating to 400 mg twice a day after 1 to 2 months. A lower incidence of toxicity was noted in the patients who crossed over to the higher dose of 400 mg twice daily. 167 The results from these trials in the USA and Europe confirmed the exceptional activity of imatinib in controlling metastatic GIST, with objective responses in 45% to 53%, as well as control of symptoms and prolonged survival in comparison with historical controls. The median time to objective response was more than 3 months, although some patients experienced dramatic disease regressions within a week after starting imatinib oral dosing. Imatinib was well tolerated overall in both studies. Based on these trials, the FDA approved the use of imatinib for treatment of metastatic or unresectable GIST in 2002 in the USA. Approval in Europe and the rest of the world followed quickly thereafter. Correlative molecular studies were performed in conjunction with the U.S. Finland trial as well as the Phase 3 trials run by SWOG and EORT. 43,168 These studies documented differences in the activity of imatinib on the basis of the genotype of the GIST lesions treated. Specifically, patients whose GISTs harbored KIT mutations in exon 11, the most common molecular subtype, had higher rates of objective response and more durable disease control than patients whose disease had exon 9 KIT mutations or no detectable KIT mutations. The meta-analysis of the Phase 3 SWOG and EORT studies demonstrated a benefit in PFS in those with KIT exon 9 mutations who initiated therapy at 400 mg twice daily, although overall survival was not different, and may have reflected the ability to increase from 400 mg to 400 mg twice daily in the setting of disease progression. 169 Imatinib-sensitive PTK mutations also benefited, with the exception of those with a D842V mutation that is refractory of approved kinases. 17,43,168 The studies of imatinib in advanced GIST have consistently documented the tolerability of imatinib overall. 121,164,166,167 It is fortunate that normal physiologic processes, e.g., hematopoiesis, that depend on the normal receptor ligand signaling through the KIT receptor do not fail with fatal consequences when KIT Table 33.2 Anti-tumor responses to imatinib in patients with metastatic or unresectable gastrointestinal stromal tumors references GISTs, N, imatinib dose, mg/day, CR, %, PR, %, DSD, %. 164-36-400, 100-000-53-17-121-147 or 600-054-28 167-946-400 versus 805-47-32 166-746-400 versus 804-41-23 There were no significant differences in anti-tumor responses among doses in these studies. CR, complete remission, DSD, durable stable disease, GISTs, gastrointestinal stromal tumors, PR, partial remission. 468 Part 4 Topics involving multiple organs function is blocked by imatinib therapy. The adverse effects of imatinib are generally mild, grade 1 or 2, and include edema, especially notable in the loose subcutaneous tissues of the facial periorbital region, diarrhea, myalgia, or musculoskeletal pain, rashes, and headache. Myelotoxicity has been much less common in GIST patients than in patients with CML treated with imatinib. Nonetheless, GIST patients treated with imatinib can occasionally exhibit severe cytopenias. Because of this risk, patients should be monitored carefully. The most worrisome adverse events observed in imatinib treatment of patients with advanced GIST have included hemorrhages from abdominal or GI sites in approximately 5% of GIST patients, largely related to bleeding from bulky tumor masses. Bleeding is thought to be induced by the potent and rapid anti-tumor effects of imatinib. In patients with toxicity from imatinib, dose reductions may reduce toxicity and allow for continued therapy. Most side effects of imatinib therapy become milder over time, suggesting that some sort of tachyphylaxis mechanism may be present. 170 For example, the edema associated with imatinib therapy of GIST often improves with continued dosing over time, although diuretics may be used judiciously and are often effective at managing this side effect. Counseling GIST patients on the use of a low-salt diet may also aid in controlling this side effect. Nausea with imatinib administration is usually mild and self-limited. Patients should be counseled to take the daily dose with a low-fat meal and a large glass of water. Antiemetics can be used if symptoms are more severe. Diarrhea is typically managed with antidiarrheal drugs as needed. Muscle cramps, frequently in the calves, are usually transient and self-limited, often mitigated by increased fluid and electrolyte intake. Imatinib rapidly and dramatically leads to decrease in the tumor's 18F-FDG tracer uptake on functional PET imaging. See Fig 33.5.120. The decreased 18F-FDG in tumors can be detected as early as 24 hours following a single dose of imatinib. The PET findings were also highly reliable, correlating both with beneficial response to imatinib and documenting progressive disease in the small subset of patients with primary resistance to imatinib. These data indicate that functional imaging of GIST with 18F-FDG PET scanning represents a useful diagnostic modality for early response assessment with imatinib therapy. PET, however, should not be considered the standard imaging modality for ongoing treatment assessment given the increased exposure to radiation as well as greater cost associated with its use. The optimal duration of imatinib for patients with metastatic GIST has been defined as lifelong therapy on the basis of current evidence. 171,172 A randomized study by the French Sarcoma Group tested the impact of discontinuing imatinib therapy in GIST patients whose disease was stable or had responded following 1, 3, or 5 years of therapy. Discontinuation of imatinib was associated with rapidly recurring disease. The best management of metastatic disease requires medical oncologists, surgeons, radiologists, and nuclear medicine imaging experts collaborating closely to determine the best course of action for any given patient. 173 Resistance to imatinib can be primary and manifest as rapid progression of disease despite initial imatinib dosing. However, primary imatinib resistance is relatively uncommon and has been found to be primarily associated with PTK4D842V and other non-imatinib sensitive oncologic drivers. See Table 33.2.43. Alternatively, imatinib-resistant disease may emerge after more than 1 or 2 years of durable response due to clonal evolution of the GIST. 174 This secondary resistance to imatinib in GIST is overall similar to the resistance mechanisms that have been described in imatinib-resistant CML. 175 Sunitinib Malate Sunitinib, SUTENT, inhibits multiple receptor tyrosine kinases, including KIT, platelet-derived growth factor receptors alpha and beta, VEGF. Receptors 1, 2, and 3, FMS like tyrosine kinase 3 receptor, FLT3, macrophage colony stimulating factor receptor, CSF1R, and glial cell line-derived neurotropic factor receptor, RET, rearranged during transfection, .176 Sunitinib demonstrated antineoplastic activity in GISTs in the first phase I clinical trial. .176 The study tested several doses and schedules and picked 50 mg orally for 28 days, with 14 days of rest as the schedule to be developed. The patients included in the phase I and subsequent phase II trials of sunitinib were for the most part refractory to imatinib and had extensive metastatic disease. PET scans demonstrated metabolic response during the 4 weeks of sunitinib treatment, but with reactivation of metabolic activity during the 2-week rest period, washout. Similar to imatinib, CT scan responses evolved more slowly. Response data in the early trials as well as the pivotal placebo-controlled phase III trial were markedly similar, with no complete responses and partial responses ranging from 7% to 13%. .176-178 Median time to tumor progression was 7.8 months and median survival was 19.8 months in the early phase studies. In the phase III trial that led to the regulatory approval of sunitinib, 312 patients with metastatic or surgically unresectable GIST following failure of imatinib therapy due to resistance or intolerance were randomized to receive sunitinib 50 mg/day, N equals 207, or to placebo, N equals 105, using the dosing schedule of 4 weeks of drug dosing followed by a 2-week period off drug. .177,178 The primary endpoint of the study was disease control as assessed by time to progression, TTP. The trial was unblinded early when a planned interim efficacy analysis showed that sunitinib was associated with a significant improvement in median TTP of more than 4-fold compared with placebo. The PFS for patients receiving sunitinib was significantly greater than for those receiving placebo, sunitinib, 24.1 weeks versus placebo, 6.0 weeks with a hazard ratio of 0.335. P equals 0.0001. In the initial analysis, sunitinib also significantly improved overall survival, hazard ratio, 0.49. At the time of the interim analysis, the median overall survival had not been reached in the group receiving sunitinib. In the final analysis, TTP was similar to the findings of the interim analysis, 6.7 months versus 1.6 months. The overall survival was also improved in the patients who initiated therapy on sunitinib, despite the crossover design of the study, 18.2 months versus 16.2 months. 87% of patients assigned to the placebo arm received therapy with open-label sunitinib. Molecular analysis of GIST samples from the initial phase I and II trials indicated that primary and secondary mutations in KIT affected treatment outcomes with sunitinib in patients with imatinib-resistant GISTs. Insufficient numbers of patients with PTK from mutations limited assessment of this group. .179 Responses and clinical benefit were observed more frequently in patients with mutations that are less sensitive to imatinib such as KIT exon 9 and wild-type KIT, compared to those with exon 11 mutations. TTP was longest for patients whose tumors contained a KIT exon 9 mutation, followed by wild-type KIT, exon 11 mutated, and worst for a tumor with both an exon 11 mutation and a new mutation. Patients with KIT exon 9 and wild-type mutations had the best overall survival. This does not suggest that sunitinib is inactive in exon 11 tumors, rather, it represents the fact that patients with exon 11 mutations who have progressed on imatinib have developed resistance, and typically have clones with additional mutations. Further study has shown that secondary mutations involving KIT exons 13 or 14 are sensitive to sunitinib, whereas those with exon 17 and 18 secondary mutations tend to be resistant to sunitinib. .179,180 Structural biology analyses of these mutated kinases have provided insight as to how sunitinib can inhibit kinase function when mutations encode certain amino acid changes that induce steric hindrance to the binding and inhibition of imatinib. .181 For some patients, the treatment schedule with a 2-week treatment break was accompanied by resumption of disease-related symptoms. However, they clearly needed a dose interruption to Chapter 33 Gastrointestinal Stromal Tumors 469-33 Manage side effects. The most common grade 3 and 4 sunitinib toxicities in GIST patients included fatigue, asymptomatic serum lipase and amylase increases, and hypertension. 176-178 Other side effects included nausea, diarrhea, stomatitis, hand-foot syndrome, anemia, and skin discoloration. Bleeding has also been described at sites of tumor biopsies when patients were on the drug. Patients on sunitinib also experienced a greater incidence of skin abnormalities, including palmar-plantar erythrodysesthesia, hand-foot syndrome, and oral cavity mucosal irritation. In addition, some patients with a history of coronary artery disease were found to have asymptomatic cardiac enzyme elevations. Certain patients also may have cardiac dysfunction, which in general reverses with discontinuation of sunitinib dosing. 182 Hypothyroidism has also been observed and mandates monitoring for emergence during therapy. 183 A phase 2 trial of continuous daily but lower sunitinib dosing was tested in patients with GISTs. 184 This dosing schedule sought to mitigate drug-related side effects, but also to control disease-related symptoms seen during the 2-week break. The study demonstrated safety and tolerability using a starting sunitinib dose of 37.5 mg daily. Types of toxicities are similar with either schedule, but of less intensity with the lower dose, allowing for continuous dosing. There was a suggestion of longer disease control with the daily dosing schedule. This regimen is preferred by most practitioners. Thus, sunitinib appears to have unique activity for the management of imatinib-resistant GIST as second-line therapy, but the powerful inhibition of a number of other kinase signaling pathways is associated with more unpleasant or medically relevant adverse effects that require close monitoring and possibly adjustment of dosing. Regorafenib. The most recently approved agent is regorafenib, Stivarga. It has multiple targets including KIT, platelet-derived growth factor receptor, vascular endothelial growth factor receptor 1R3, TIE2, RET, fibroblast growth factor receptor 1, RAF, and P38 mitogen activated protein kinase. 185-186 The initial phase 2 trial in GIST demonstrated a response rate of 17.6% and a clinical benefit rate of 76%, defined as those with objective responses or stable disease for greater than or equal to 16 weeks. In addition, the median PFS was 13.2 months. 185-186 These compelling phase 2 data led to the GRID study, an international double-blind phase 3 trial of regorafenib compared with placebo using the same criteria for study entry regarding prior treatment as in the phase 2 study. 187 The trial randomized 199 patients in a 2:1 fashion to regorafenib versus placebo, allowing for open-label therapy with regorafenib at the time of progression for both patients on either arm. The overall response rates, ORRs, were very low at 4.5% for regorafenib and 1.5% for placebo, one partial response. The median PFS was 4.8 months with regorafenib versus 0.9 months on placebo. Overall survival was not statistically significant and anticipated, given that 85% of the patients on placebo crossed over to active therapy. Toxicities for this agent were more similar to sunitinib than imatinib. The most common toxicities noted in the phase 2 trial were hand-foot syndrome, fatigue, diarrhea, and hypertension, affecting 91%, 85%, 79%, and 76%, respectively, of patients, most commonly during the first cycle of therapy. 185 Overall, 67% of patients experienced at least one or more grade 3/4 toxicity while on the study. In the phase 3 study, drug-related adverse events were more common in the regorafenib arm than in the placebo arm, 98.5% versus 68.2%, respectively, with grade 3 or higher events noted in 61.4% versus 13.6%, respectively. The most common grade 3 or higher events in the regorafenib arm were hypertension, 23.5%, hand-foot skin reaction, 19.7%, and diarrhea, 5.3%. 185 Analysis of factors associated with improved PFS with regorafenib from the phase 3 study determined a benefit for tumors with both primary mutations in KIT exon 11 and 9, irrespective of what line of therapy, third or beyond. 187 The only factor that trended toward favoring placebo was prior imatinib therapy of less than 6 months duration. An analysis of clinical benefit from the Phase 2 study documented 76% of patients benefited, with the greatest benefit being in SDH-deficient tumors, 100%, exon 11 mutated tumors, 79%, and exon 9 mutated tumors, 67%. 187 There was one patient with a BRAF exon 15 mutation who did not benefit. There were 3 patients with unknown genotype, 2 of whom derived clinical benefit. Alternative agents. A number of other agents have been evaluated in GIST, with a certain level of clinical efficacy demonstrated largely in limited Phase 2 trials, which have not led to FDA approval. Review of all these agents is beyond the scope of this chapter. Some agents approved for alternate indications can have a role in patients with advanced disease who are physically well enough to continue therapy and for whom there is not an appropriate clinical trial option. Table 33.3 lists the agents and studies supporting their use. Nilotinib is the best studied agent. Initial Phase I data testing nilotinib alone or with imatinib demonstrated safety and tolerability, with some suggestion of activity. 188 Subsequent studies, including 2 Phase 3 studies, were conducted that did not support its indication in GIST. 189,190 in first-line therapy in patients with metastatic GIST, compared to imatinib, nilotinib was found to be not as effective as imatinib, particularly for tumors with exon 9 mutations. 189 There has been much discussion of the Phase 3 trial. In patients with advanced disease who failed both imatinib and sunitinib that allowed ongoing kinase therapy in the control arm, had the study been placebo-controlled, some have speculated the trial would have been positive for an improvement in PFS. 190 Other single-agent kinase inhibitors available, FDA approved for other indications, have some evidence of limited benefit in GISTs, including sorafenib, pazopanib, and dasatinib, primarily for D842V mutant GIST. See Table 33.3. 58,191 to 200 Table 33.3 Non-FDA approved agents in the management of gastrointestinal stromal tumors. Agent disease setting study phase references nilotinib I/IB 188 metastatic first line compared to imatinib 3 189 metastatic third line following progression on imatinib and sunitinib, compared to best supportive care and ongoing kinase therapy 3 190 sorafenib second line setting or beyond 2 191 to 193 pazopanib third and fourth line setting 2 194,195 dasatinib third and fourth line setting 2 196 everolimus second and third line setting I/2 197 dabrafenib not applicable. Case report 58 larotrectinib not applicable. I-203 470 Part 4 Topics involving multiple organs. Combination therapies have been assessed with the rationale of inhibiting the KIT pathway as well as another molecule in the same pathway or alternate pathway. Imatinib plus everolimus, an inhibitor of the serine threonine kinase mTOR, was evaluated in patients who progressed following imatinib and at least one other TKI. 197 Investigators found that 37% of patients were free of progression when receiving imatinib 600 mg with everolimus 2.5 mg daily. The addition of an MEK inhibitor binimetinib to imatinib has been shown to be safe. An ongoing study is evaluating its efficacy in first-line metastatic disease. 198 Because mutated kinase proteins maintain dependence on the protective chaperone function of the heat shock protein 90, HSP90, 199 studies with a variety HSP90 inhibitors alone 200,201 or in combination 202 with imatinib have been conducted. Early phase I2 trial experience with the HSP90 inhibitor IPI504 were encouraging, but the agent is no longer in development. 200 and the HSP90 inhibitor B11B021 has led to partial remissions in a few patients with refractory disease. 201 It is, however, doubtful that any of the HSP90 agents will be approved for treatment in GIST. For rare patients with BRAF mutations, dabrafenib has demonstrated activity. 58 More recently, GIST with NTRK translocations have been reported with response to larotrectinib. 203 Future agents Blue 285, also known as avapritinib, has been tested in the phase I setting with expansion cohorts in a variety of GIST subtypes. 204 This agent was optimized to inhibit kinase mutations involving the distal kinase domain, where secondary mutations commonly occur. 205 This region is also the location of the PTK4D842V mutation that is refractory to standard therapies. Activity from the phase I trial in GIST has been reported in abstract form only to date, NCT 02508532, but is notable for significant activity against GIST with PTK4D842V mutations that are refractory to approved kinases. 204 In the first report from the phase I study, of 17 PTK4D842V patients with one or more disease response assessments, 7 had a confirmed partial response, or of 41%, and 10 had stable disease. These results are quite remarkable given the lack of activity of approved agents for this genotype. In addition to this remarkable activity in PTK4D842V GIST, benefit has also been seen in disease with other KIT and PTK4 mutations that are refractory to standard therapy, with prolonged disease control. The phase 3 Voyager study of avapritinib compared with regorafenib is underway in the third-line setting, NCT 03465722. DCC 2618 uses a novel approach to treatment for GIST. 206,207 KIT has an interior switch pocket, with two portions of the kinase serving as an inhibitory switch, exon 11 juxtamembrane domain, or activation switch, exon 17 activation loop. Mutations in exon 11 render the kinase constitutively active, which fortunately can be inhibited by approved kinase inhibitors that function as ADP competitive inhibitors. However, mutations in exon 17 are not inhibited. DCC 2618 was designed to block access to the switch pocket by the activation loop, rendering the kinase inactive. Given the similar structure of PTK4 to KIT, it is anticipated that a similar benefit may be observed. Presentation of the phase I trial of this agent, NCT 02571036, reported that in 99 GIST patients with one or more on-study tumor assessments, the OR was 16%. 208 Further testing of this agent is underway in the INVITAS trial evaluating DCC 2618 versus placebo in patients refractory to all planned therapies, NCT 03353753. Special considerations: imaging of clonal progression when monitoring malignancies for disease response to therapy. Progression is associated with an increase in size of disease. In clinical research, this has been standardized with the use of RECIST criteria that defines progression as an increase of measurable lesions by 20% or more, as well as the appearance of new disease. 209 As discussed above, CCT and MRI, with the use of TKI therapy in GIST, benefit from therapy can also be assessed by a decrease in tumor density using Choi criteria. Within metastatic lesions that are responding, progression can be identified with the development of a new nodule that has increased density or enhancement. 210 Genomic studies of these new lesions have identified new mutations accounting for resistance to therapy and thus progression. 211 Review of CT and MRI imaging must be done with care to identify these lesions. Carney triad and the Carney-Streitakes dyad. Carney triad was first described in the 1970s. 212 Young patients, often females, were reported to present with gastric leiomyosarcomas, paragangliomas, and pulmonary chondromas. 213 We now appreciate that the gastric tumors were GISTs, often multifocal with lymph node involvement. 213 The description of the triad has evolved and may now include adrenal adenomas and esophageal leiomyomas. 214 The Carney-Streitakes dyad, Carney-Streitakes syndrome, was described and included patients with a family history of paragangliomas and GIST. 215,216 Both these syndromes have GIST that lack mutations in KIT or PTK4. They are characterized by lack of expression of SDHB by immunohistochemistry staining. Evaluation of these tumors and genetic testing has identified that tumors that are part of the dyad carry mutations in the SDH family of genes, whereas those associated with the triad do not have such mutations. 57 For clinicians and patients, the importance of the distinction is imperative. Patients who present with gastric GISTs that are found to lack SDHB expression by immunohistochemistry staining require a referral for genetic counseling to determine if the patient has the dyad with a germline mutation, those with the dyad need ongoing screening for paragangliomas that can occur in the neck, chest, and abdomen, as well as consideration of genetic counseling and screening of other family members. Management of patients with SDH-deficient GIST has unique features. These tumors are often multifocal and can present with bleeding. At presentation, it is not unusual to find lymph node metastases, and they can metastasize to the liver. However, their clinical course can be quite indolent, so care of these patients must balance the control of symptoms with the potential morbidity of symptoms. Aggressive gastric resections to eradicate disease is not recommended. Rather, these patients are best managed with selective surgical procedures to manage lesions that are causing symptoms. 217 For patients who do have disease that is metastatic and progressing, the benefit of kinase inhibitors is not entirely clear. This is in part because of the evolution of tumor mutation testing. Earlier studies used assays that missed mutations in KIT or PTFRA or did not even require testing. Although there are reports of imatinib being of benefit 44,168,169, it is now believed that for most patients it is ineffective. There are reports of benefit for sunitinib and regorafenib in patients with SDH-deficient GIST. 186,218 Familial gastrointestinal stromal tumors. In addition to the carne stratocchi's dyad, GIST rarely can be associated with familial inheritance patterns. 293233,46-48,216 In several of these families, KIT mutations have been reported. These familial cases tend to have autosomal dominant germline mutations, and the GISTs seen in affected members tend to be multifocal. Additional clinical characteristics of affected family members include cutaneous lesions such as hyperpigmentation or skin lesions that resemble the clinical appearance of urticaria. Chapter 33 Gastrointestinal stromal tumors. 471 33 Pigmentosa. These skin pigmentation abnormalities may be due to the effect of the mutationally activated KIT kinase function on melanocyte growth and development. The mechanisms whereby such pigmentation disorders remain focal rather than disseminated may provide clues as to why GIST lesions may take decades to appear in these rare familial cases. It should be noted that there also are reports of familial PTFRA-associated mutations. Familial cases of GIST have also been identified with germline PTFRA mutations. 46-48. Members of the family with the mutation were noted to have large hands as well as GIST, in contrast to non-affected family members. Another case of a germline PTFRA mutation described an association with multiple fibrous polyps and lipomas of the intestine. 47 More recently, PTFRA mutant syndrome has been described that includes GIST, but also inflammatory fibroid polyps and fibrous tumors. 48 This syndrome is associated with mutations in PTFRA exon 14, which is an uncommon mutation in GIST. Other genetic tumor syndromes associated with gastrointestinal stromal tumors. Patients with neurofibromatosis type I, NF1, have an increased risk of GIST, as well as other malignancies. 220-223 Molecular analysis of GIST lesions arising in patients with NF1 has documented that these GISTs often do not harbor detectable mutations in the KIT or PTFRA gene, but they may, so molecular testing should be performed. 220-221 Tumors with the classic mutations respond to standard therapies as would be expected. For those that do not have the typical genetic alterations, systemic therapy with standard agents appears to have limited benefit, although the literature on outcomes in this small subset of tumors is very limited. One would not anticipate response based on targeting KIT and PTFRA, but the anti-angiogenic effects may have some utility. In NF1-driven tumors, the disease may present with multifocal lesions in the abdominal cavity, with an indolent course over time. Watchful waiting is a very reasonable option in this group of patients. Gastrointestinal stromal tumors in children. GISTs rarely can affect children. 224 to 226 Pediatric GISTs typically are what we formerly called W195 ILD type GISTs, and now are understood to be SDH-deficient GISTs. Initial evaluation of these tumors identified few molecular alterations. 225,226 guidelines for GISTs in children and young adults have been published. 227.